Good morning, everyone. Today we begin with Chapter 6, the biomedical basis of chronic disease. Up to now, much of our public health story has been about germs, bacteria, viruses, infections. But today the story changes. We are going to look at the disease that quietly developed over years. The one that now kill most people in developed countries, the heart diseases, cancer, and diabetes. In this lecture, in the part 1, I will discuss the first one, cardiovascular diseases. And by the end of this lecture, you will understand not just what this disease is, but how scientists figure out their causes and why that matters for preventions. Before we dive in this lecture, let's look at the key terms of this chapter. These seven terms will appear again and again: cardiovascular disease, atherosclerosis, cholesterol, hypertension, diabetes, cancer, and mutation. Don't worry about memorizing definition right now. We will unpack each one in context as we go. I just want you to recognize them when they appear and to notice that several of them, like cholesterol, hypertension, atherosclerosis, are all connected to that single big category, cardiovascular disease. So, how did we get here? Why are chronic disease suddenly the main concern? Let's look at the historical shift, the epidemiologic shift. Here, a key idea: public health was a victim of its own success. When we controlled infectious diseases through sanitation, through vaccines, through antibiotics, people stopped dying young from infection. This shift began around the 1920s, but people still have to die something. So, as we lived longer, the chronic degenerative disease, heart disease, and cancer especially rose the top. Now, the important public health point is the last line. These are not only diseases of the elderly, they also strike people in their prime, taking away productive years of life. That's what makes them a public health priority, not just a medical one. Let's put some numbers to this, which disease actually lead to list. Notice the nouns here. If you ask which disease kills the most people overall, the answer is cardiovascular disease. But if you narrow to the American aged 45 to 65 people in midlife, the cancer the cancer takes the lead, with cardiovascular disease close second. Then there are a second tier: diabetes, arthritis, Alzheimer disease. These may not kill quickly, but they devastate quality of life. And that's the dual mission of public health. I want you to hold into. We fight both premature death and disability. Now, you would think that with all our science, preventing these would be straightforward. It isn't. Let me explain why. Why chronic diseases are hard to prevent. With infectious disease, prevention is conceptually simple. Find the germ, block the germ. With the chronic disease, there's no germ. There is no single pathogen for cancer or heart disease. Instead, these diseases have multiple causes acting together, with which makes it very hard to pin down which risk uh, which risk factors actually matter. And they developed slowly over decades, so the cause and the effect are separated by years. Imagine trying to prove that something you ate at age 20 caused a tumor at age 60. That's the challenge. But the slow development is not all bad news. It actually gives us one important opening, one advantage: early detection. Here is the silver lining. Because chronic disease developed gradually, there is often a window where we can catch them early, before symptoms, before damage is done. This is what we call secondary prevention, intervening early in the disease process to reduce its impact. Keep this term in mind because it will come back when we talk about cholesterol screening, blood pressure check, and diabetes diagnosis. So, who is doing all this research to understand these diseases? In the United States, the answer is largely one institute. Let's look at this institute, the National Institute of Health, NIH. The growth of the National Institutes of Health, NIH. The National Institutes of Health is the engine of biomedical research in the United States, and its history mirror our story exactly. Look at the timeline. It started in 1887 as a single room laboratory of hygiene focused on infectious disease, fitting the priorities of that era. Then, watch the shift. In 1937, the National Cancer Institute. In 1948, the Heart Institute, now NHLPI, Heart Institute, created. Today, there are 27 institutes and centers, most of them focused on chronic disease. The growth of the National Institute of Health is the growth of our concern about chronic disease, made visible in budget and buildings. Now, how does the NIH, the National Institute of Health, and scientists everywhere actually study these causes? There are toolkits, two main toolkits for the answer. How does the National Institute of Health and scientists everywhere actually study these causes? So, research methods for chronic disease. So, I mean, two toolkits, two approach work together. The first, epidemiology, and the second, lab animal experiments. For the first, the epidemiology mostly observes. We watch what happens spontaneously in population because ethics won't let us deliberately give people diseases. The second, laboratory research, especially animal experiments. In the lab, we can control condition tightly, which let us prove cause and effect in a way observation alone never can. So, epidemiology spots the patterns, the lab confirms the mechanism. And when we say animal models, the workhorses are mice and rats. So, why mice and rats? Two reasons. The first, they are mammals, so they share most our biochemistry and physiology. What happens in the mouse cell is often close to what happens in ours body or in ours. Second is very practically. They have short lifespan. We can watch the entire effect of an exposure or treatment unfold over a couple of years instead of waiting a human lifetime. That makes them efficient, efficient stand-ins for us. But this is crucial. Animal models are not perfect substitutes. Here is where they fall short. The limitation of animal model. Mammals can differ unpredictable ways. A chemicals that deadly to one species may be harmless to another. The striking example, a dose of dioxin that kills a guinea pig has no effect on a mouse or rat. So if you only tested it in mice, you might wrongly conclude it's safe. The lesson, never assume result in one animal automatically apply to humans. Sometimes the bigger problem is not a flawed model, it's having no good model at all. The clearest example is AIDS. Finding the right animal model aids example. A good animal model can accelerate research enormously, but finding one is not always possible. For AIDS, there is no good animal model, and that has uh, genuinely slowed drug and vaccine development. The closest substitutes are Asian monkey infected with SIV, a cousin of HIV. Only chimpanzee can actually be infected with HIV itself, but we no longer use them for ethical reasons and because of cost. So, the absence of a model itself a major scientific obstacle. When animals are not suitable, scientists turn to an ever simpler system: cells in a dish. Cell and tissue culture. That's me. We have gotten very good at growing cells and tissues in laboratory glassware in the dish. This is fast, cheap, and great for testing whether chemicals cause cancer, and much IV research was done this way. But there is the catch: a dish is an oversimplified word. It strips away all the complex interaction of a living body. The dramatic example: several drugs that killed HIV in the test tube turned out to be useless in actual patients. So, culture results are starting point, never the final word. Never the final word. At right, okay, we now have our toolkit. Let's apply it to our first and most successful case study: the cardiovascular disease. Again, cardiovascular disease. In this slide, just I will talk about the overview of this disease. Cardiovascular disease is our success story, so we will spend real time here. First, the basics. It covers two of the three leading causes of death: heart disease and stroke. And notice the risk pattern. It rises with age. It's higher in men than women, and higher in black American than white American. Those disparities matter. Hold into them because they tell us prevention effort must be targeted, not one size fit all. Why do I call this success story? You know, because we actually figure out the causes. And one study above all made that possible. Established causes of cardiovascular disease. The Framingham or the Framingham, this is the name of the scientist. The Framingham study is one of the most famous in all of the public health. By following a whole town over decades, it nailed down three major risk factors: high blood cholesterol, high blood pressure, and smoking. These three. Notice why cardiovascular disease was easier to crack than cancer. It's common, so there is lots of data. It progresses similarly across patients, so there is a pattern. And critically, blood is easy to study. You can draw it from anyone without much discomfort or ethical objection. That's accessibility unlocked everything. So, what actually happens inside the arteries? Let's open one up. The core process is called atherosclerosis. Atherosclerosis means hardening of the arteries. When pathologists examined people who died of heart attacks, they found plaques that build up on the inner lining of arteries. And look at what the plaque is made of: fat, cholesterol, blood cells, and clotting materials. If you imagine the arteries as a pipe, plaque is the gunk narrowing the pipe from the inside. This is a good example. Exactly. Now, here is something that should uh, genuinely surprised you. This process start far earlier than most people imagine. Blake begins early. This is one of the most arresting facts in the chapter. Blake doesn't wait for old age. Fat strikes the very first stage, were found in half of children age 10 to 14 who died in accidents. And the famous 1955 study of soldiers killed in the Korean War found that 77% of them, average age just 22, already had signs of atherosclerosis. So, the disease of the elderly actually begins in childhood. And it's worse in those with risk factors like smoking, hypertension, obesity, high, low density lipoprotein, or high bad cholesterol level. If it starts that early, what drives it? Animal study pointed straight at diet and Blake. Here is a beautifully experiment. Rabbits are naturally vegetarian. When researchers fed them milk, meat, and eggs instead, they developed a plaque that looked remarkably like a human plaque. Then a human cohort study confirmed the flip side. Diet rich in fruits and vegetables reduce atherosclerosis and heart disease. Put those together and you can deduce why the typical American diet, heavy in animal products, light in produce, feed our high rate of cardiovascular disease. We know diet matters, but what's the actual mechanism? How does cholesterol turn into the heart attack? How plaque forms? Picture it as healing process gone wrong. High cholesterol plus smoking, high blood pressure, and diabetes repeatedly injure the arteries in our wall. The body tries to repair that injury, but the repair runs out of control and becomes a disease in itself. The more cholesterol and fat in the blood, the faster the scab like plaque grows and the deadly final the plaque ruptures, releasing clots that block the artery in the heart or the brain. That's your heart attack or stroke. Now, here's a more recent and surprising twist. Atherosclerosis might be partly infectious. Just when we thought we understand it, new evidence suggests an infectious angle. Bacteria are often found inside the plaque. The blood cells in a plaque looks like an immune response. And the chemistry suggests atherosclerosis is actually inflammatory conditions like arthritis than we expected. This is still emerging science, but if it holds up, it could open entirely new ways to prevent, to diagnose, and treat the disease. We now know the major risk factor. So the cutting edge question becomes what determines whether you have those risk factors in the first place? This is where modern research lives. We have learned the major risk factors. Now we ask what controls them. We have discovered the cholesterol is not one thing, there are different lipids, each playing distinct role. We have studied what rise and lowers blood pressure. We know diabetes amplifies cardiovascular disease. And here is the empowering conclusion. What is the conclusion? All these factors are partly genetic, but can be significantly modified by behavior. That's precisely what makes them targets for public health intervention. We can't change your gene, but we can change your diet and habits. So let's zoom in on each major risk factor, starting with the most famous one, the cholesterol. Here are the numbers worth remembering. At 20 milligram per deciliter or below, cholesterol is desirable, and people at that level have less than half of the heart attack risk of those above 240. So the gap between desirable and high is not trivial. It's more than double the risk. But this is the next slide point. The total cholesterol is only part of the story because not cholesterol is the same. This is the good versus the distinction you have probably heard about. The HDL, the good cholesterol, versus LDL, bad cholesterol. Most blood cholesterol is bound to protein, and the type of protein matters enormously. HDL, high density lipoprotein, is the good cholesterol. The more of it you have, the lower your risk. The LDL, low density lipoprotein, is the bad cholesterol. More of it means higher risk. So, two people with identical total cholesterol can have very different risk depending on their HDL and or LDL balance. That's why modern testing looks at the breakdown, not just the total. So, if cholesterol matters this much, how do we actually change it? And here, the conventional wisdom has shifted. Diet, lifestyle, and cholesterol. This slide overturns something your parents were probably told. For years, the advice was avoid eggs and high cholesterol foods. But newer evidence says dietary cholesterol is not the main source of blood cholesterol. The real to under the real is the saturated fat, trans fat, and too few fruits and vegetables. Other points to note: vegetarian have lower cholesterol. Vigorous exercise lowers total cholesterol and rises HDL cholesterol. Fish, olive oil, and whole grains help, and smoking also lowers your good cholesterol, lowers the HDL. But genetics is still set the stage. Some people can eat fat freely with little effect, while others struggle no matter what. When lifestyle is not enough, medicine step in, and one class of drug has exploded in use: the statin. Statins. Look at this growth from about 11 million Americans on statin from 1999 to 43 millions by 2014. That's a near quadrupling in 15 years, and the evidence is solid. Statin prevent heart attacks even in people whose cholesterol was previously thought normal, and they are generally safe long term. So, what's the problem? From public health lens, there is something uncomfortable about prescribing lifelong drugs to healthy people when diet and exercise might do the same job. Plus, some statins are expensive. Okay, primary versus secondary prevention for the cardiovascular disease. This is a concept I want you to truly internalize. Statin are secondary prevention for people who already have atherosclerosis or are high risk. But the preferable approach is always a primary prevention, stopping the disease from ever developing. That means exercise, not smoking, and healthy diet. The honest caveat the textbook adds is important. Eating healthy is not always easy in American society. And that's the hint that prevention is as much about environment and policy as personal willpower. Now, to the second major risk factor and a major cause of stroke, specifically the hypertension. Hypertension means high blood pressure, is a major driver of cardiovascular disease, especially stroke, and it also damages the kidneys. Here is the frustrating part. In most cases, we don't know the cause. We call that essential hypertension. Essential here just meaning the unknown cause. What we do are the associated factor: obesity, smoking, lack exercise, excess salt, and stress. Notice these overlap heavily with the cholesterol risk factor. The same healthy lifestyle fights both. Before we go further, let's make sure everyone actually understand what those two blood pressure numbers mean. There is a systolic blood pressure and there is a diastolic. When you see a reading like 140 over 90, the top, the number systolic, is the pressure when your heart contracts and pushes the blood out. That's the peak. The bottom number is diastolic, is the pressure between beats when the heart relaxes. So in 140 over 90 is a systolic and 90 is a diastolic. 140 is systolic and 90 is a diastolic. Keep this straight because the guidelines we are about to discuss are all about these numbers. And those guidelines have changed quite a bit over time. Next, I will discuss a great example of science being self correcting. Look at this table. How the safe threshold has crept downward. For a long time, 140 over 90 millimeter mercury was the borderline. In 2003, the NHLPI said normal is below 120 over 80 and invented the category pre-hypertension for everything in between. Interestingly, 20, 22 years cohort study then pushed back, suggesting keeping systolic under 140 was what really mattered. But then big 2015 study changed minds again. And by 2017, the American Heart Association AHA set 130 as the new cut-off point for high blood pressure. So less than 130. The takeaway is not to memorize every number. It is to see that guidelines evolve as evidence accumulates. Let's look closely at the, the pivotal 2015 study because its results were dramatic enough to stop it really. This study of over 9,300 older adults was actually halted early, and that only happens when the results are so clearly beneficial that it would be unethical to continue withholding the treatment from the control group. Aiming for 120 rather than 140, reduce heart attack, heart failure, and stroke. All reduce heart failure, reduce stroke by a third, and reduce death by quarter. So again, aiming for 120 rather than 140, reduce the heart attack, heart failure, and stroke by a third, and reduce death by quarter. Those are huge numbers, and they why guidelines tightened. Knowing the science is one thing, but has public health action on blood pressure actually worked? Yes, and here the proof. Blood pressure awareness program. There is a genuine public health victory. After government launched a blood pressure awareness program in 1972, the annual rate of fatal strokes was cut by more than half, down to 73 per 100,000 in 2015. How? The same trio, healthy diet, exercise, sorry, no smoking, plus secondary prevention. Knowing your own number and treating high blood pressure with drugs if necessary. This shows that awareness campaigns, not just medicine, save lives. Salt, dietary salts, and hypertension. Salts is believed to cause some essential hypertension. But here, the wrinkle: sensitivity to salts varies, and it's probably genetic. The rat studies show this beautifully. Some strains developed high blood pressure on high salt diet. Others don't react at all. Some sensitive strains even have stroke under salt plus stress. Federal guidance says limit salt to 2300 milligram daily, about 1 teaspoon, but most American blew right past that. Even if individual sensitivity varies, the population level picture is much clearer. Salt at the population level. Step back from individual to whole population and the pattern sharpens. Group eating more sodium have more hypertension, and in the United States eat more than many countries. The prevalence is striking: 1 in 3 adults and about 65% of those over 60 years. And the average is real. Dropping average systolic pressure by just 5 points would cut stroke death by 14%. The key insight for policy: most of our salts concern from packaged food and restaurant meals, not for the salt shaker. So the 2003 recommendation targeted the food industry, not just individuals. Our third major risk factors ties back the theme that runs through this entire course: the tobacco. Smoking. Smoking and cardiovascular disease. Smoking harms the cardiovascular system through two components: nicotine and carbon monoxide. Nicotine, the addictive part, is a stimulant. It raises blood pressure and pulse, releases stress hormones, and irritates the heart and vessels. Carbon monoxide is a poison gas that latches onto hemoglobin and block it from carrying oxygen. Long term, both contribute to atherosclerosis. Short term, they can trigger heart rhythm irregulation or irregulatories that cause sudden death. And smoking danger is especially stark in one group you might not expect: the young. Smoking in younger adult. Heart attack are rare in your 30s or and 40s, but when they do happen at the age and that at that age, they are likely caused by smoking. In fact, young smokers have five times, not not small number, 5 times the heart attack rates of non-smokers their age. So heart attack in young person is more often than not tobacco story. That completes our deep dive into cardiovascular disease, our success story. So now you know why I name the success story of the cardiovascular disease. Thank you for your attention and see you in the next part of the same chapter to discuss other diseases like diabetes and cancer. See you and goodbye.